This is Michael Smith of MedPage Today. I'm in Vienna at the International AIDS Conference, where I'm speaking with Dr. Melanie Thompson of the AIDS Research Consortium of Atlanta. Dr. Thompson is the lead author on the 2008 guidelines for antiretroviral therapy issued by the International AIDS Society USA. Dr. Thompson, this is the second time in a row that these guidelines have, in a sense, expanded, strengthened the recommendations for HIV treatment in terms of who should get care. Can you sort of briefly tell us what you've done in these guidelines?
So in 2008, our recommendations were to begin therapy before the CD4 cell count fell to 350 or below. And now we are recommending that therapy should be started when the CD4 cell count is 500 or below. So during this past 2 years, what has happened is that evidence has accumulated to bring home the importance of the harmful effects of uncontrolled HIV in terms of immune activation, chronic inflammation, non-AIDS diseases such as cardiovascular disease, hepatic disease, renal disease, and even malignancies. So these new findings really beg the question of what is asymptomatic, because patients are now doing well in terms of preventing AIDS-related infections typically, but they're beginning to have a raft of other sorts of problems. So earlier therapy is one way to address this chronic inflammation that occurs at any CD4 cell count. But we feel the data now support recommending therapy at 500 or below. The other important factor moving us toward this is the availability of potent, durable, tolerable, and simple drug therapies, not just for initial infection, but for infection in the second, third, fourth regimen.
I see. So the number of choices that are available and the improvement in the drugs lowers the risks of the treatment, while we know more about the harms that not treating people has causes. Let me ask you this. Is there a level at which a CD4 count is so high that treatment should not take place?
Well, the panel has taken the stance that there is no CD4 cell count above which therapy is contraindicated. But we do know that the evidence increases as the CD4 cell count declines. So I think our other recommendation regarding asymptomatic infection is that CD4 cell counts above 500 would be circumstances where you would consider therapy, but in an individual basis. Now, there also are a variety of conditions where we recommend treatment regardless of CD4 cell count, and those are conditions like pregnancy, hepatitis B or C co-infection, the cardiovascular disease, risk or active cardiovascular disease, opportunistic infections, including tuberculosis, an age greater than 60 years old, which was not previously recognized as a reason to start therapy, high risk for transmission of HIV. So there actually are a whole list of comorbidities that CD4 cell count becomes relatively irrelevant in terms of treatment.
Mm-hmm. Now, you obviously, the guidelines cover much more than simply when to start therapy, and I guess our audience can look for those in the current issue of the Journal of the American Medical Association. Let me, though, explore this issue of when to start a little more deeply, because I think our audience, many of them are physicians and doctors who treat HIV patients. They are aware of some of the barriers to this, and that is that there is a lack of funding. There's a lack of money for drugs. How do we reconcile expanding the recommendations while at the same time there are many people whose CD4 counts are even below 200 and therefore actually count as having AIDS who can't get medications?
It's a very important question of increasing relevance in the United States in particular. But I think it's important to realize that the guidelines are scientific. We aim at best science, best medicine. And we hope that even though we know that these are not currently achievable in our economic downturn, it's important to have a goal. It's important to be driven by science, and for that science to advocate for the kind of health systems, the kind of health resources that we need to take care of people with HIV.
Okay. Are you sort of looking forward to the new National AIDS strategy, perhaps as a way to move that forward?
Very exciting to have a national AIDS strategy after 30 years. We're very excited to see how the national AIDS strategy rolls out, to see what the funding will be to support the national AIDS strategy. But like the guidelines, I think the national AIDS strategy right now is a goal. And the Obama administration has set some very specific goals for HIV testing and for entry into care and so on. But these goals are not funded entirely right now. But without a strategy, you don't know where you're going. And you don't have the guidance to be able to target the appropriate funding and to target changes to the public health infrastructure that we need to make in order to do the best medicine and to care for every patient in the United States who has HIV.
Right. Well, thank you very much, Dr. Thompson. This is very informative.
Thank you.
In Vienna, I'm Michael Smith, MedPage Today.